Good morning, good afternoon, good evening, wherever you are. My name is Miriam Mutebi, and I'm a breast surgical oncologist working at the Aga Khan University Hospital in Nairobi, Kenya. And I just want to welcome you to our inaugural edition of the African Cancer Dialogues. The African Cancer Dialogues is a series of continental conversations where we look at new evidence that's either been generated locally, regionally, or on an international basis, and see how they can translate into best oncological care in our centers. And in order to make this series real and pragmatic, we've put together a group of African cancer experts who are going to be commenting on different aspects of care, common cancers, and looking at different aspects of treatment, whether surgical, medical, palliative or supportive care, or around health systems and research in the value of cancer care. We're very excited to have Dr. Werner van der Poy from Ghana and Dr. Sitna Mwanzi from Kenya, who will briefly introduce themselves before we get into the nuts and bolts of things. Welcome.
Okay, so my name is Dr. Werner van der Poy. I work in the Kolebu Teaching Hospital. I'm a clinical oncologist and a treasurer for African Organization for Research and Treatment in Cancer. And I am an ASCO member for almost 15 years now.
Hello, everyone. I'm Dr. Sitna Mwanzi. I'm a medical oncologist working at the Aga Khan University here in Nairobi, and currently the chair of the Kenya Society of Hematology and Oncology, and a member of AORTIC and ASCO as well. So happy to be here today.
Thank you, Werner and Sitna. I think that we're going to quickly dive straight into it and ask you about, you were both able to attend the breast portion of the meeting. And I think for us, we would be interested to figure out what abstracts stood out for you and why. And maybe you could give us a bit of detail around the session and what you felt were the highlights.
I think I'll let Sitna go first because she's in charge of this one.
I think that breast is always an important topic because it's one of the most common cancers. And there were actually about 461 sessions, abstracts, and posters during the ASCO meeting. So obviously I wasn't able to attend all of them, but we had a look at all the abstracts. There are very many big data sets that came out. But what I was looking for is what would be important for oncologists in Africa. For this series, we were told to come up with 4 abstracts, and I think my first list had like maybe 15, and we had to narrow it down. So it wasn't very easy. Of course, there is data on all the different molecular subtypes of cancer. There was data on surgical oncology, clinical radiation oncology, and medical oncology. So for me, I was looking at what would be something that an African oncologist would be interested in. Maybe Vanna can add to that.
Oh no, I think you've done justice to it. Like I said, we realized the differences with the COVID is that it's difficult finding time to sit down behind the computer to get through all of this. So, but of course, breast is number one, and it really impacts us in Africa, because we have a lot of gaps in the differences in the way we manage them. So they don't always translate into what we have in Africa. So we have 2 abstracts that we zoned on in. I don't know if Miriam is able, are you able to read them? I can't switch between
I can't, but I think one of the abstracts that you talked about, Sitna, you can?
Yes.
Got to do with the hormone receptor positive breast cancer, and maybe you can tell us a little about that.
Okay, so we narrowed down to 2 abstracts. So the first one was actually on the management of the axilla after neoadjuvant chemotherapy. And the second one was about disparities in molecular profile in young Black women in the States. So if I can start with the second abstract. So basically this was a retrospective review of the molecular profile in a cohort of patients in America. and they looked at the molecular profile of young Black women and compared it to a cohort of young white women. And the ethos behind this is that we know that there is a difference in outcomes of breast cancer patients when you compare the Caucasian population and the Black African population. So what they did is they looked at the subtypes luminal A, the basal-like, and the HER2 enriched in the both cohorts. And what they found was that the young Black women were more likely to have the basal type and the HER2 enriched, and they were more likely to have larger size tumors and a higher grade of tumor and a higher risk of recurrence even when they had early breast cancer. So as compared to the white cohort population. So this may not be really like new findings, but I think it's important to document these findings. The reason it was interesting for me is that many times when we talk about breast cancer in Africa, we try and use this data to extrapolate the data from America to us. For me, I think what it highlights for me is that even in Africa, we have variability. Not all African women are the same. We have differences in the West African population and in the East African population. So in as much as this data is comparing a Caucasian population and a Black African population, we might not be able to directly infer that our African patients will have a similar molecular profile, and means that we need to do our own studies to evaluate this further. I don't know if Werner has anything to add.
Actually, I do. So I looked at the abstract, and what I saw was that there was a little bit of a mix-up with the terminology. So it looks like they were mixing up non-luminal versus non-luminal A, because I didn't like the way they presented their results. And what they said was true, that most of them tend to be younger and all that. It made it look as if we had very little luminal, both A and B, but that is not exactly true. So I think it's the way the terminology was put. Non-luminal actually kind of like mixed up with non-luminal A. So I think that's where the issues were. And we all know that luminal B also has bad outcomes. And it's something that a lot of people just don't talk about. They don't respond to hormonal therapy and they don't respond to chemotherapy either. So we are in trouble for having more of luminal Bs in terms of our outcome. I'll say most of these studies, unfortunately, were done in America. And we know that Africans, they actually have a mixture. There's like a whole genetic pool. Somebody might have like belonging to like 10 ethnic groups. So it's difficult to skew it out for Africa. And I think, like Sentinel said, we do need a study just right here. The lessons we've learned is that even though for many years we said ERPR was mostly negative in Africa, it was because of the quality of the tests, which Clement Adebayo said many years ago. And now that we have improved our testing capabilities, we know that at least half of our patients are ERPR positive. Unfortunately, very few are luminal A, but then they're supposed to do better than the other types of cancer. So I think what it brings out is that we need to do our own studies to actually get what exactly is happening in Africa. We know they come late, their outcomes are poor, but it also could be because they are just coming late. They are doing more of alternative medicines or praying before they come. So their diseases are advanced by the time to get to us. Unfortunately, they don't have the money, and we don't have that much of universal health care in Africa as well. That might be why the outcomes are actually poorer. So we really do need to do studies in Africa to see what the impact is. We know it's bad, but the reasons are multifactorial. It might actually be cultural as well, and just the health systems, and not really just the genetics. We really need to find that out. So this has actually opened a can of worms for us in Africa. Thanks.
Yeah. Thanks, Werner and Sitna. I mean, I take your points around the multifaceted approach to the factors that may be resulting in patients being diagnosed with more advanced disease, and of course, the factors those directly impact on their outcomes. I think the paper sort of tried to focus specifically around the non-luminal cancers that were still hormone receptor positive, which we know is a very small subset. And the question that we had, I mean, at least in terms of consideration, is you did raise the point around genetic testing. And I think that, as you said, opens up a can of worms, because the next question is, how common is that in your setting, and what are the cost implications? And is this something that is readily feasible in our setting?
I think the physicians are just assuming that it is difficult, but it is not. If you tell a patient, I needed to do your treatments, they usually do come forward to pay. So I think we have to insist, and it should be part of the histology bill. So it's not just telling me the character of the tumor, but I also want to know the molecular signature of that tumor. So I think it's something that the pathologists need to make sure it is part of the testing. So it has to be done together and not separately. I think that is the biggest gap. And you can't take any of them out either. So I know people have said, why don't you take out HER2 since it's the most effective? But it also tells you whether you are triple negative or not in the treatment. So the best thing is to be able to give you personalized care, the best care possible. I need to do your molecular profiling. And then I think the discussion doesn't help. Just add it to the cost of the pathology. So the same way you need to know the type of histology, you need to know the molecular profiling as well. It's a non-starter, if you ask me. I think in Africa, things are getting so much better. It's still expensive. The access is still low. I'm talking about those, of course, in the cancer centers, in the big hospitals. We need to do a lot more to improve access to the more rural areas. And that is something that the governments will have to take care of. But for now, I think it looks so much better than it used to be about 10 years ago. So we are getting there, just at a slower pace as usual.
So, and I agree with Vanna. I think one of the challenges is we need to talk to our pathology colleagues and say that if you send a report without an ER, PR, and HER2 for breast cancer, then that's an inadequate report. It's the same way that they will give you the grade and they will tell you whether it's ductal or lobular. This is such a key part of it that the kind of reporting we get is that we've done this, it's an invasive ductal carcinoma grade 2, and then you have to request the receptor status separately. That is not an appropriate way of doing things. It actually causes delays, and this is a test that will get missed. Now we talk to our colleagues and tell them this report is inadequate because it doesn't have this ERP and HER2. It's the same way that you will report on lymphomas, and if you don't add the immunohistochemistry for CD20 and the other markers, then it's not appropriate for managing patients.
What about the gene profiling? Because of course we want to say a standard of care, and that should rightly be so. In terms of for management, you need to know what the ER, PR, HER2 status of the tumor is. But then again, we know moving beyond that gene profiling, that could potentially have implications in treatment of these patients and either de-escalating therapies that they're receiving. So what would be your comments around that?
I think we really haven't gotten the ERP or the basic treatment right yet. So it would be a little bit far-fetched to start talking about that. But I think when we get our head, forward with the basic, I don't think we do what kind of, I'm not sure we are doing RNA PAM50. This was a PAM50 study. The testing was done based on PAM50, but we are not quite there yet. But I think we can't jump the loop when we haven't really solidified the basis yet. So I think that is the next thing to look at. Even now, it's culturally difficult to even talk about BRCA testing in my patients because they are not going to follow with their recommendations because of cultural differences. That's another research topic by itself. So, and it's expensive, unfortunately, for us now. So I think the things that would affect the therapy, we can do upfront. Because even if they are BRCA positive and they can't afford the medications, really, what did I really know? It costs more anxiety. It's a whole new research topic by itself, believe me, as to how they assimilate that information and what to do next. Yeah. So I think genetic filing is probably for the next decade. It's taken us so long to just accept the importance of ERPR testing. So I think it's a little bit far-fetched for now. But in places where it's affordable, it's available, I think it's worth pushing it forward.
I would just add and say that it's something that we could do within our research as a research for our patients, because if it's done under research, then the cost is catered for. It may not be widely available, but it's something for us to aspire to, because it's probably becoming more and more important to have this information. So as Varna said, we're not there yet, but it's something important for us to aspire to.
You also talked about a second abstract.
Okay, so the second abstract is interesting to me because more and more in Africa and in Kenya, we are doing adjuvant treatment. And then once you've done your adjuvant treatment, the question always is, what do we do with the axilla? Like before the neoadjuvant, when we were doing adjuvant treatment, then it was when we were doing upfront surgery, it was clearer what to do with the axilla. But now with neoadjuvant treatment, if a patient is node positive at the beginning, how do you manage the axilla? Do you go for a complete axillary node dissection, or do you do a sentinel lymph node biopsy? So this second abstract was actually it was a survey that was done in Brazil for Brazilian breast surgeons. And I thought that was important because Brazil is kind of in a similar situation to us in terms of being a developing country. And just to find out what breast surgeons there were doing or were thinking about doing in terms of axillary management after neoadjuvant treatment. So for me, what was interesting was that they were using more and more sentinel lymph node biopsy, even if there was not a complete pathological response. So in patients who had isolated tumor cells or micrometastasis, about 40 to 43% of the surgeons were doing a sentinel lymph node biopsy, but at least a quarter or a fifth of surgeons were also doing it if the nodes were N3 or N2. So I found that was interesting. And for us, we would more often do axillary node dissection, like a full dissection. So this is interesting to us because we with more availability of chemotherapy, and because we have larger tumors, we are more likely to use neoadjuvant chemotherapy. So it's more important for us to understand what are the things that we should do once there's a response, and how do we manage the axilla. I know, Miriam, this will be interesting for you.
No, for sure. It's very valid consideration, because I mean, there hasn't been any clear consensus on what to do with the axilla, especially after neoadjuvant chemotherapy. And there have been several trials that have tried to look at how should we appropriately manage the axilla. I mean, all the way back from 2013, there's a Sentinel trial that tried to look at, are there patients who would actually upfront get a sentinel lymph node biopsy versus those who would get them post neoadjuvant chemo, and sort of looking at what would be the false negative rates. And the whole point behind those particular trials has been the unacceptably high false negative rate. And of course, there have been certain maneuvers that they have tried to improve on over the years, trying to see how we can improve the accuracy post neoadjuvant. The ASCO 1071 that tried to look at, again, the same question in patients who've had neoadjuvant chemo. But then again, their conclusion was the very high false negative rate, still more than 10%, which is what is acceptable. But I mean, current thinking has been moving towards what they're calling targeted axillary dissection. And but that involves several maneuvers, such as putting a clip into the identified node that's positive before the neoadjuvant chemo, and getting both the sentinel node and the identified node at the time of surgery. And several initial studies do look promising for validation of the targeted axillary dissection technique. But of course, it still harks back, and I'd be interested to hear Werner's comments on this. It still comes down fundamentally to a lack of both skills and nuclear medicine facilities. Of course, for sub-Saharan Africa, they have been trying to come up with innovations like MagSeed and Sentimag that use magnetic filings to identify the sentinel node, as opposed to the constraints of nuclear medicine. But I'd like to hear from Werner, what is your take on the management, at least in Ghana or in West Africa currently, of the neoadjuvant post chemotherapy?
Okay, the first thing I want to say, there's not much sentinel node going on in this part of Africa. We have a few of my surgeons who are kind of like trying it out to see what they can do. So it's more like on a trial basis. We also tried a little study to see if we can use an ultrasound to try and help to determine, like see what the correlation is between an ultrasound and a sentinel node biopsy after the dissection to see what the response rate is, but we never really got to that. The problem I have with this is that it looks like the jury is surely out on early N0, clinically N0 nodes, okay, for sentinel node biopsy. The jury is not out yet on locally advanced tumor, which is like N2, N3. If you look at the survey, they said even for N2, they do a sentinel node after the neoadjuvant. For me, I think it's too early to come out with that because we know that after somebody has a sentinel node after neoadjuvant chemotherapy, there's even a high false negative rate with that. Okay, so I'm not sure how to leverage the two. I think there are a few studies that are going on now that will help to answer the question, whether to just add radiation, even if the node is positive, the neoadjuvant chemo, or to go ahead with the dissection. So for now, I think the results are not in yet. It's almost like taking chloroquine for COVID without the evidence. We all see what the outcomes are. And I think patients' life are at risk with this one. So I think the onus is on us in developing countries who see these advanced cases to actually do these studies in our own environments to see what the outcomes are. Because I think in as much as we're in a hurry to get rid of axillary node dissection, we really can't do that yet. The exception I'll say is mainly for those who have and clinically N0 after neoadjuvant chemo. That is something that you could look at. But when the axilla is positive, clinically positive after neoadjuvant chemo, I'll be very reluctant to go ahead and just do a sentinel node biopsy. So I think we have to develop some criteria as to how to do this. Maybe the PET scan could help. Some people have used that too. So you do a PET scan, and if it's negative, then you consider a sentinel node. I really don't know what the answer is. But a sentinel node by itself for an axilla that there's no complete clinical response, I'll be very reluctant to do that because the jury is not yet out. You could infer that once the person has a complete pathological response rate, then it's almost equivalent to an N0. You could actually say that, and then, but then when it's positive, I'm not too happy about that. And I know the radiotherapy is not really a way of, they tried many studies before and they didn't really get rid of the tumor in lieu of an axillary dissection. So I really don't know what the answer is, but for me, I think it's too early right now.
So I was saying that the reason I thought that the abstract was interesting was for several reasons for African oncologists. One is that how are we doing our neoadjuvant treatment currently? Because I think in other centers, what they do, they put a clip both in the primary tumor, and then how do you evaluate the axilla before the treatment starts? So at least our practice here at Aga Khan is to actually identify whether the lymph nodes are present or not by doing an ultrasound. And then we also confirm whether it's involved by doing an FNA or a biopsy. And then where possible, putting the clip in so that you know what you're looking for. So this might not be readily available in many centers. And then if we do this after the end of treatment, do we actually reevaluate patients and say what kind of response they have had radiologically? So before you go for surgery, are we doing the ultrasound and the mammogram again of both the primary breast and the axilla? So I think these are two key things that we need to reflect on as we are looking at the studies. And as Miriam has said, the management of the axilla after neoadjuvant treatment, there's really no consensus on what to do, whether you're going to do a full node dissection, whether you're going to do a node biopsy, and then if that's positive, converting that to a full axillary dissection, or whether just to omit everything and do radiotherapy for the axilla. So as we're using more and more neoadjuvant treatment, we need to just be clear on how are we doing it? Are we doing it the right way? And how are we assessing patients after? And or what modalities are we going to be using for management of the axilla afterwards?
Some people have also lost the clips, after, so it's still not, like a definite way. I don't know. So I think the risk is lower in the NO disease than in the N2, maybe even the N1. So I think maybe we should have to be able to have studies to look at N1 versus N2 versus whatever. And that might help to tell us where the guideline should be as to what to do. But to swallow it blindly, I really wish I was there to ask the presenter, I mean, what informed them of using it for, M2 disease as well, because the data is still not strong on that.
And I think that's the fundamental, I think that's the cautionary tale that I think is emerging from some of this data, because all they were doing was a survey, and what we're seeing is a lot of heterogeneity. And sometimes, unfortunately, this heterogeneity is pushed by maybe one or two studies that show maybe some benefit, and then have people have them as practice changing. Certainly, in terms of the targeted axillary dissection that we were referring to with a clip and multiple nodes, the presumption is that the patient has had a complete pathological response. And of course, I think pretty much in terms of whether the axilla is still heavy, is positive with the positive disease, I don't think any recommendation would be to attempt a sentinel lymph node biopsy in that context. It might not even work, because if the nodes are still tumor heavy, then you might not necessarily actually be able to have sort of any pickup of the whatever you're using, whether it's the magnetic filings or the radionuclide or the dye, just because the lymph node is completely infiltrated by tumor and would be essentially negative. So I think in terms of management, we all need to err from the side of safety. And so we would say in such recommendations where it's still experimental and things are sort of still haven't been clarified in terms of what is the stringent criteria that one would sort of qualify for doing a targeted axillary clearance, then the safer thing I think to do, at least at this stage, would still be to go ahead and do a formal axillary dissection. And one would say is their role for research, certainly, and one could sort of say design a study where you're maybe doing targeted axillary dissection, but having the axillary clearance that you're doing at the same sitting as your control to see what are our findings in our setting. Can this actually be applied in this context, and what is the criteria or patient profile that we're looking at who would actually probably benefit from these sort of less aggressive procedures. But I would say, at least as far as locally advanced disease is concerned, then one would still err towards doing a completion axillary dissection. Yeah.
Is there anything that we can do to the impact of the axillary dissection? There must be
for
newer
sure. For sure, there is. I think the main concern that you worry about is the lymphedema. Is that correct?
Yes.
Yes.
I mean, amongst the patients that you're seeing, of course, there are a number of complications, but the most common, at least in 10 to 15 of patients, seems to be lymphedema, which sometimes could be early onset or even late onset after they get their radiotherapy. I think from a technical perspective, there is a role. I mean, the standard of care currently is doing what you call a level 2 dissection, which is basically identifying the little intra-op, identifying the little pectoralis minor muscle and removing all the nodes below that. Now, what tends to happen, and this is the beauty of neoadjuvant chemotherapy, because what used to happen years ago is you'd have a heavy bulky disease all the way up, and people would end up doing level 3 dissections, which again would give you really, really severe morbidity in terms of lymphedema. And we're saying, just if the patient has a very heavy nodal disease burden, then the appropriate thing to do, basically neoadjuvant chemo is a surgeon's best friend, because you're able to hopefully get an optimal response and avoid more aggressive surgery to the axilla. Of course, even within a level 2 dissection, which at least minimizes your chances of lymphedema, there's still a chance of developing that. And so, of course, the idea is diligence, because we are seeing these patients on follow-up, couple of, it's practical things that you need to tell the patient as part of their care post-operatively. Simple things like avoiding tight or constrictive clothing around, or like wristwatches or bracelets on the arm that's had the surgery, things like protecting the hand if you're going to be out in the field, we're a agricultural society. If you're going to be digging, protect the hands. Or if you're going to be in an urban setting, make sure that you have hand protection, especially if you're doing things like washing dishes with really complex steel rolls. So those are the practical things that we tell our patients. But the other thing is, as clinicians, we also need to keep an eye out, because it's a very subtle presentation. But if we're able to pick it up early and start the patient on appropriate either occupational therapy, exercises that they can do at home. Sometimes patients, depending on the setting, may have access to compression sleeves, and then that minimizes the chances of them having the lymphedema progressing, and also minimizes the chances of developing cellulitis, which could then further exacerbate the lymphedema. So those are the practical sort of points that we do need to tell both patients and clinicians to watch out for. And part of their reviews when they're coming for their top up of their medication or therapy, it's a quick thing to quickly look at the wrist, look at the elbow, just to sort of see if there's any fullness, as a quick assessment to see whether they're developing lymphedema. And that those at least increase the chances of them being picked up early and being addressed appropriately.
Okay.
So I think one of the things that I wanted to add is what Verna said, that sentinel lymph node biopsy is not very readily available in many African countries, but I think it's something that we need to really look at developing. And I liked that there are other methods being evaluated apart from using nuclear medicine. So as we are progressing with other things, like we talked about our pathology, even our surgical techniques are things that we need to really work on improving, because ultimately patients are going to need less and less extensive auxiliary surgery as we are doing more and more upfront treatments.
Yeah, and that's absolutely correct, because though as Verna was saying, the jury is still out on locally advanced disease, I mean, for early disease, that question has been answered. And of course, as we get into increasing awareness, public campaigns and advocacy from both non-governmental organizations and the health fraternity, we're definitely seeing more and more patients presenting or getting diagnosed with earlier cancers. And so then we sort of have the other extreme, where you have patients, for instance, with a small foci of DCIS getting an aggressive axillary clearance, which is suboptimal, and again with the attendant complications. So for sure, with early breast cancer, there is a definite role for sentinel lymph node biopsies. Studies like the ASCO Z11 looked at the question around, as Verna was saying, if you have a sentinel node that's positive, but you're having a patient who's going to have breast conservation and radiotherapy, then in certain select patients, you don't actually need to do more aggressive surgery. That's the provision of radiotherapy is still considered curative and definitive for that patient, as opposed to going ahead and doing more aggressive surgery. So for sure, as Sitna and Verna have said, as you both said, these are things that we do need to look at, even as we develop all these other services, to sort of see how we can, one, not only increase the skill set, but also homogenize the training. Because as you probably know, and you could prove me wrong, in terms of what we call a modified radical mastectomy varies from center to center, and what you as the oncologist are invariably getting is very heterogeneous. So also homogenizing surgical skills and provision to care will ultimately be a win, I think, for the patients.
Agreed.
Yeah.
Yeah.
Any parting thoughts or any highlights that you feel needed to be?
I think it'll be a subject, it'll be a good subject to discuss at the next AORTIC meeting, managing the axilla for your surgical oncology and the general oncology. I think it'll be a very interesting topic to get experiences from different parts of Africa, to see what they do, and then you take it up from there. Yeah.
Sitna, any parting thoughts?
So my parting shorts is that there was a lot of data presented from a medical oncology point of view. As we are getting more and more targets for patients, there are more and more drugs. For example, for the HER2 positive patients, there was more data on in the HERCLIMB study on tucatinib in combination with trastuzumab and capecitabine. Not forgetting treatments that target the cyclin-dependent kinase 4 and 6. So I think I would encourage all the people who can get access to actually go through all the abstracts. We weren't able to talk about all of them, but there's a lot of data that would be interesting. Even if we cannot apply that data to our current setting, it's still important to keep abreast of what is going on in the rest of.
That's what I was going to say. We don't have to have access. You need to know. Yeah.
Yeah, and that's part of what the African Cancer Dialogues is about. I mean, this is a very short snippet of time, but a couple of minutes that we're talking about sort of what the highlights are. But the idea is going forward that we're going to have a series of webinars addressing some of the concerns that both yourself, Berna, and Sitna have raised around, for instance, auxiliary management, doing a deeper dive into the issues around breast cancer, and having a candid discussion around how do we move the needle in terms of improving health systems and access to care for our patients, and ensuring that best practice is provided irrespective of whichever, whether you're in West, East, or Southern Africa. The standard of care should be the same across the board.
Yeah.
Yes, I agree.
Yeah.
All right, thank you, Dr. Sitna Mwanzi and Dr. Werner van der Pooy, for your incredible insights into this meeting. It's been lovely touching base with you and getting highlights around this, and we're looking forward to having you both participate in the subsequent webinar with a hopefully larger panel of people who we can have a very vibrant discussion with. Thank you. Goodbye.
Thank you.